وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleague, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to send my apology for the technical issues that I had in my laptop, so that's why there was some kind of little delay. However, we would like to welcome you all here in this scientific event, which we are going to shed light on healthy digestive system during the month of Ramadan. And in this occasion, I would like to extend my congratulations and a greeting for the holy month of Ramadan. وجعل الله صياما مقبولا وعملا صالحا مرفوعا، وبإذن الله تتحقق الغايات وتتحقق البركات والثواب إن شاء الله في هذا الشهر الفضيل. I would like to extend my thanks to our guest speakers who are going to join us here today and enrich our scientific event with their presence and their wealth of information. We have Dr. Muhammad Zahri and Dr. Raouf Haji. And I would like to extend my thanks to Shtada Company for giving us this wonderful opportunity to be together today and to share the knowledge and exchange experience in a very important topic, which is the digestive system symptoms that we encounter throughout the year, with a special focus during the month of Ramadan. So without any further ado, I would like to mention that this is an online session, and I would like to encourage all the virtually attending candidate audience to put their questions in the Q&A box, so we'll be able to send a question to the speakers at the end of this session. So I would like to introduce the first speaker, Dr. Raouf Haji. He's an assistant professor of internal medicine, and he's a consultant of internal medicine Wasat and Jubail in Saudi Arabia. Dr. Raouf, he's contributed to the medical field as an author, reviewer, and editor, and he has a lot of contributions, in fact, in the scientific educational events. So I would like to welcome you, Dr. Raouf, on behalf of all the attendees. And the topic which we are going to share today is the gas bloating and belching approach to evaluation and the management in primary care. We know that primary care become a cornerstone for our healthcare system in the kingdom, and they count on us as a primary care to manage our patients with the state-of-art of practice and to ensure the quality of care that we are looking for, inshallah, by treating those patients with this kind of symptomatology, gases, bloating, and belching. So thank you once again, Dr. Raouf, for being with us here today and accepting our invitation. And I would like to leave the floor for you, please.
Assalamu alaikum, Ramadan Mubarak and healthy Ramadan for all. And I'm elated to be here among you to speak about gas, bloating, and belching approach to evaluation and management in primary care. Did you know that up to 30% of the population experiences bloating and gas regularly, making it one of the most common gastrointestinal complaints in primary care? Yet, despite its prevalence, many patients struggle to find relief, and healthcare providers often face challenges in effective management. Moreover, their causes are very diverse. The evaluation of the patient with gas, bloating, and belching can be complex and treatment extremely challenging. Today, we'll explore underlying cause of gas, bloating, and belching, delve into practical diagnosis approach, and clear management strategy that can be easily integrated in primary care healthcare practice. Gas-related symptom can impair the health, markedly impair the health-related quality of life. In such situation, many patients express their embarrassment during their daily work with colleagues and the meeting. Despite the increasing of number of promising pharmacotherapies and intervention and dietary intervention that may help alleviate these symptoms in an effective way, an effective management strategy can be hard to elucidate, frustrating both patient and healthcare professional. We will present here some key aspects of history and physical examination that facilitate the further assessment and management of gas-related symptoms. The pathophysiology, the etiology is very complex, multifactorial, and completely understood. The etiology of chronic abdominal bloating is complex, often multifactorial in nature, and completely understood. The differential diagnoses include both organic and functional disorder, And we see that common causes of chronic bloating and distension are divided onto organic and disorder of gut and brain interaction. We start by small intestinal bacterial overgrowth, SIBO, lactose, fructose, and other carbohydrate intolerances, celiac disease, pancreatic insufficiency, bariatric surgery, gastric outlet obstruction, and gastroparesis, and all. The other section is disorder of gut and brain interaction. Especially the main one is the irritable bowel syndrome. Most of patients believe that their symptoms are due to increased amount of gas within the gastrointestinal tract, although this accounts for symptoms on only a minority of patients. Normal gas production, absorption, and excretion is illustrated in this figure 1. The computed tomography imaging has shown that liminal gas increases in only 25% with functional gastrointestinal disorders during a spontaneous episode of abdominal distension or following consumption of high flatness diet. The following section highlight the major pathophysiological causes of bloating and distension, like small intestinal bacterial overgrowth, carbohydrate intolerance, altered microbiota, abnormal gastrointestinal motility, pelvic floor dysfunction, abdominophrenic dyssynergia, and visceral hypersensitivity. A simplified 5-step approach to the clinic history. The initial approach to the patient with the GRS is to obtain a detailed history and perform a physical examination. We propose simple 5-step approach to the clinical history supplemented by a key physical examination finding, which can facilitate the workup. We start by the first step is clarify the predominant symptom as well as time of onset. The predominant symptom can be belching or bloating, should be ascertained initially to help direct questioning. Next, the timing of the onset of symptoms relative to food ingestion should be also clarified. The onset of symptoms soon after the eating suggests a gastric etiology, whereas delayed symptoms may suggest a small bowel origin. We need also to perform thorough dietary evaluation. Primary care physician should explore patient eating patterns and the relationship symptoms. The patient should be asked to describe how much and how frequently they eat. Eating large meals less frequently may contribute to postprandial discomfort. Eating meals quickly without enough chewing and gulping food may contribute to GRS. Some patients may associate the symptom with ingestion of food associated with increased intestinal gas production, such as onions, beans, and legumes. Intolerance of food types containing lactose, gluten, and fructose may also be related to gas. The patient may have experienced GRS improvement with prior dietary modification, and this should be pursued in the history. The patient should be asked about the consumption of larger quantity of caffeine, carbonated drinks, as these can contribute to GRS. Belching, in particular, can be associated with caffeine ingestion because transient lower esophageal sphincter relaxation, artificial sweetener, specific like such as sorbitol, mannitol, glycerol, promote gas production, and frequent use of such products should be sought in the clinical history of these patients. These are often contained in chewing gum, even if sugar-free. Ask about associated gastrointestinal symptoms, specifically abdominal pain, diarrhea, constipation, and weight loss. The coexistence of abdominal pain, alteration of bowel habit, and abdominal bloating suggests the potential diagnosis of IBS. However, many other conditions leading to GRS may also cause abdominal pain. The patient should be questioned about the form and the frequency of stool, the ease of stool passage, and as constipation can induce GRS. The presence of incomplete evacuation of stool straining with defecation or manual removal of stool suggests diagnosis of pelvic floor dysfunction. The presence of diarrhea should prompt consideration of a small intestine bacterial overgrowth, SIBO, and celiac disease. Weight loss history should always be sought in patients presenting with gastrointestinal symptoms. Substantial weight loss raises concern for an underlying neoplasm or malabsorptive conditions, such as celiac disease. Patients with a severely restricted caloric intake sometimes due to dietary intolerance or even functional dyspepsia, may also report a marked weight loss. We need to review also the patient medication and inquire about supplements. Medication review is necessary in all patients with chronic unexplained gastrointestinal symptoms. Specific to GRS, the patient should be questioned about the respective psyllium containing products which may contribute to excess gas production. Metformin and opiate are also associated with GRS. We need also to explore the patient comorbidity and ask about the risk factors for SIBO. The use of continuous positive airway pressure for obstructive sleep apnea is associated with GRS, typically with morning symptoms following overnight use. New users may require alteration of continuous positive airway pressure settings to minimize these effects. Patients receiving home oxygen therapy can also experience gaseous symptoms. Approximately 25% experience gas bloat syndrome after Nissen fundoplication surgery, and history of this the same should be sought. Small intestine bacterial overgrowth can manifest as GRS. The risk factor of SIBO should be sought in the history and include the following: structural. We need to check for small bowel diverticular strictures due to Crohn's disease or radiation, or non-steroidal anti-inflammatory drugs. Surgical like ONI surgery, blind and afferent loops, and ileocecal valves resection. Dysmotility, like in the situation of scleroderma, narcotics, diabetic mellitus, amyloidosis, reduced acid achloride, acid suppressive therapy, gastric resection, atrophic gastritis, and advanced age, miscellaneous like celiac disease, cirrhosis, immunodeficiency, and pancreatic insufficiency. The effect this is the table about the effect of dietary choices for determining possible cause of functional gastrointestinal disorders. Like you see that the artificial sweeteners like sugar, free gum specifically, can cause bloating and often with diarrhea. Caffeinated beverage, coffee or soda, can cause belching and diarrhea, but less likely to cause bloating. Can decrease lower esophageal sphincter pressure, which causes belching. Carbonated drinks, soda and other carbonated beverage, excess of gas and bloating. Bolting and gulping food, eating quickly, not doing enough showing food, routinely chewing gum, cause belching and bloating gas. Over time, over-the-counter medication, especially antacid containing magnesium, can cause diarrhea and bloating, less likely. The size and timing of meals. Large and frequent meals eaten in the late in the day can cause bloating and distension and dyspepsia. Specific food like beans, fiber, fructans, fructose, lactose, and legumes can cause gas. We go to the second step, which is physical examination. The clues to the etiology of gaseous symptoms may be encountered by patient observation during the history taken. Occasionally, a patient presenting with evaluation of belching will be observed to belch excessively when attention is focused on his symptom. The patient may even volunteer on the demonstration of belching during the interview process. Improvement in belching may also be observed as patient is distracted. The observation suggests the diagnosis of supragastric belching, a learned behavior that is often associated with anxiety disorder. Examination of the abdomen may reveal distension related to small bowel ileus or mechanical obstruction, or less likely gastric outlet obstruction, whereby patient may also manifest succession splash and gastric splash. Non-gaseous etiology for abdominal distension should be considered, including ascites, organomegaly, and increased adiposity. Bowel sound should be carefully auscultated. High-pitched bowel sounds suggest mechanical obstruction, whereas reduced or absent bowel sounds could suggest gastrointestinal ileus or dysmotility. A detailed digital rectal examination should also be performed, looking for evidence of fecal impaction or sign of pelvic floor dysfunction. The signs of floor pelvic dysfunction include increased perineal descent, descending perineum syndrome, decreased perineal descent, or abdominal abnormal sphincter tone and failed relaxation in piborectalis muscle with stimulated defecation. For the investigation, there are no tests for gas and bloating. Patient fears about specific diagnosis, particularly cancer and infection, should be elicited and addressed. Testing should be done to exclude specific diagnosis, not to simply reassure the patient. I'll go directly to the figure about that resume all of this. We have gas and bloating symptoms onset less than 30 minutes. We go to gastric bloating and we'll investigate according to the gastric bloating. It can be functional dyspepsia, gastroparesia, disorder of accommodation, and gastric outlet obstruction. We need to consider upper endoscopy, hemoglobin A1C for diabetes, or gastric emptying studies. For the symptoms, if the gas and bloating is occurring more than 30 minutes after eating, it's small bowel bloating, irritable bowel syndrome, celiac disease, dietary and small intestine bacterial overgrowth. We need to do celiac serology and urea breath test. For the gas and bloating with constipation, when we have bloating with constipation, we should consider chronic idiopathic constipation, and predominant irritable bowel syndrome, dysynergic defecation, irritable bowel syndrome, dysynergic defecation like pelvic floor dysfunction, and slow transit the constipation. We need to do rectal examination, TSH, calcium, and we may refer the patient to a gastro to do colonoscopy and anorectal manometry and colonic transit study. For the belching is usually linked to the gastric belching, supragastric belching, and aerophagia. Usually, there is no test needed. For the alarms flag, the red flags, which are the alarm symptoms suggesting potentially serious causes, like gas, bloating, and belching. We need to look for abdominal mass, dysphagia, is difficulty of swallowing, extreme diarrhea symptom, large volume, bloody, nocturnal, progressive pain, does not improve with fasting, fever, gastrointestinal bleeding, melena or hematochezia, jaundice, lymphadenopathy, new onset of symptom in patient to 55 years and older, odynophagia, painful swallowing, the simple symptom of chronic pancreatitis, symptom of gastrointestinal cancer including family history, symptoms of ovarian cancer including family history, tenesmus, rectal pain or feeling of incomplete evacuation, unintentional weight loss, and vomiting. The treatment is based on mainly on reassurance about the generally benign course of the disease. The concept of biopsychological psychosocial model should be introduced for the patient. Anxiety and depression and psychosocial stressor are main factor of worsening. Combination of medication and diet are really usually effective. Several safe drugs are available. New agent for patient with complicated and intractable symptoms are available also. Most patients will have incremental improvement over the time with occasional flare-ups. In 50% of patients will have the resolution of symptom. 30% will have fluctuation. This is the initial therapy of functional and gastrointestinal disorder are based. This is stable. Resume all the treatment that we can give. That will be detailed in the next keynote. They are based on diet, probiotics, exercise, fiber, PPI, laxative, antispasmodic, opioid agonists, prokinetic agents, and neuromodulatory gut-brain axis, like tricyclic antidepressant. We can also use psychotropic agent like SSRI. This is usually the main treatment for IBS, which is the most important disease that we see in GRS. We need to improve the diet. we need to avoid FODMAP, which is fructans, disaccharides like lactose, and the monosaccharides like mainly fructose, and polyols like sorbitol and galactans. We need also to give bowel wall treatment like hyoscine, hyoscine, and the neuromodulation for continuous pain, and psychological treatment and complementary treatment. The question is, when need we refer the patient? This is the main question that we are facing. The patient is coming back to every time, many times in the week, check for, I have irritable bowel syndrome, please give me treatment. I didn't prove such treatments. It's now time to refer the patient to gastroenterologist, and referring patient with gas, bloating, and belching to the gastroenterologist can be considered under various circumstances. While these symptoms can often be managed with lifestyle adjustment or primary care guidance, there are specific situations where specialist referral is appropriate, mainly the persistent of the symptoms. If the patient symptoms are persistent, recurrent, or worsening despite initial management strategies such as dietary modification, over-the-counter medication, or lifestyle changes. Alarm features, like mainly the presence of alarms such as unintentional weight loss, gastrointestinal bleeding, anemia, difficulty of swelling, persistent vomiting, or a family history of gastrointestinal cancers. Diagnostic uncertainty. When the cause of the symptom is unclear, and this is usually the case, there is a need for further diagnostic evaluation. A gastroenterologist can perform specialized investigations such as endoscopy, colonoscopy, or imaging studies to diagnose conditions like peptic ulcers, gastritis, celiac disease, inflammatory bowel disease, or gastrointestinal cancer. The other reason is the failure of initial treatment. If the symptoms do not improve with initial treatment measures, if they recur after initial improvement, we need to refer the patient. The age consideration in all the patients, especially older than 50 years, the likelihood of serious underlying condition increases, so the referral might be considered sooner, especially if the symptoms are new or have changed in character recently. The associated symptom, if gas, bloating, and belching, are accompanied by other concerning symptoms such as severe abdominal pain, change in bowel habit, jaundice, or sign of malabsorption such as steatorrhea, fatty stools, we need to refer the patient. Under the patient request or anxiety, we need to refer the patient. Sometimes even if the clinical picture does not strongly indicate need for a specialist referral, patient anxiety or a specific request to see specialists should be considered. Clear communication about the reason for and against referral can be important in this situation. Finally, the take-home messages are: the evaluation of the patient with the GRS can often be complex and time-consuming. To this end, methodological approach can facilitate diagnosis and management. This approach should help limit differential diagnosis and direct testing, and it should also help my primary care physician and professionals to evaluate and treat the large percentage of patients with GRS. Be attentive to search for alarm in future to refer the patient at time and facilitate the early diagnosis and accurate management. Referral to a gastroenterologist should be considered in more complex and refractory cases. And thank you for your attendance.
Thank you so much, Dr. Raouf, for this wonderful illustrated presentation that you shed a light on the approach, how we are approaching a patient with bloating and belching in the primary care, and going through the different perspective of the management and even the red flags and when to refer patients. So thank you so much for this wonderful presentation. So now, ladies and gentlemen, we would like to move to the second presentation, which is going to be delivered by Dr. Muhammad Zahri. He's a gastroenterologist, consultant, head of the endoscopy unit in Mossad Hospital, Al Khobar, Saudi Arabia. And he's having a doctorate of the Tropical Medicine, Department of Gastroenterology, Hepatology and Infectious Disease, Faculty of Medicine, Cairo University in Egypt. So we are going to go through different dimensions of the topic. where we are going to translate the evidence to practice using the sympathy cone to reduce the flatulence. So this is another practical sessions where we're going to put sympathy cone in its own perspective and positioning in the management of patients with bloating and belching. So on your behalf, I would like to welcome Dr. Mohammed and thank you for accepting our invitation. And I would like to leave the floor for you.
Thank you very much, Dr. Raouf and Dr. Ashraf for the great presentation. Dr. Ashraf, thank you for the great introduction. It's my pleasure to be with you all. Dr. Raouf, thank you for your nice presentation. I start sharing this screen. It's appearing with you. You can see?
Yes, we can see it.
Yes. Okay. Let's start. Of course, Dr. Raouf will make my task more easier because he already covered most of the perspectives of the flatulence and bloating. But let's start to have some refreshment or another point of view for the topic. In Ramadan and in different times during the year, many patients are coming to the doctor. They are complaining of bloating. Sometimes we have these signs of bloating and this complaint of bloating that the patient has eaten too much or has many gases, but of course he has no distension. So we have to analyze this symptom to go through this diagnosis of this problem and trying to find a solution for this problem. If this problem is transient and this sensation is transient sensation of bloating occurs after eating, resolve spontaneously, this is nothing. We can ignore it. And of course, the patient will ignore and will not come to the doctor. On the other hand,
Dr. Mohammed, your voice. Dr. Mohammed, we lost your voice. So we are waiting for Dr. Mohammed to get into his presentation online. So just 1 minute, please. Dr. Mohammed?
Aywa, my voice is coming or not?
Yes, we can hear you now. So you can go ahead.
And slides are appearing?
Yes. Yeah, we can see introduction.
Okay,
slide.
I'm sorry. Yes.
No problem.
Maybe all of the patient will feel bloating at one time or another time. But we have to differentiate. If this bloating is transient sensation, occurs after feeding, after eating, then resolves spontaneously, so this is not a medical problem. The medical problem if there is chronic bothersome bloating or abdominal distension, and this is affecting negatively the lifestyle of the patient. And this is our topic today. It occurs in about 30% of population. One third of the population will feel this bloating. And in 90% of patients, it will be associated with IBS. Of course, more in women and more in IBS related constipation rather than IBS related diarrhea. 75% of patients with bloating, even without IBS, will characterize their symptoms as severe, moderate to severe symptoms. And 50% will report that symptoms may cause reduction in the daily activities, so it will have impact on the lifestyle of the patient and also in the economic burden of the country. That's why it's very important. The term bloating is a subjective sensation. This is the patient complaint. He will come to say, I have bloating, I have trapped gas inside my tummy. But if I found that the abdominal distension is present, it's an objective. If there is increase in the abdominal girth of the patient by physical examination, that's in this situation, I can say that this patient has abdominal distension. So bloating is the patient complaint, distension is my examination. Bloating and distension can occur independently, and sometimes and frequently they can coexist. In 50% of patients, they report bloating, we can find abdominal distension in them. And this will have an implication on the nature of the disease and the pathophysiology of the disease. For those patients, sometimes in clinical trials, they did CT for this patient and they found increase in the abdominal circumference of these patients. So they had bloating and they have distension together. How to diagnose? We have to focus on the ROM4 criteria, the criteria for diagnosis of all functional disorders. Diagnostic criteria for this: recurrent bloating and distension occurring at least 1 day per week on average. This bloating and distension should be predominant symptom and should not meet criteria for other functional disorders like IBS, functional constipation, functional diarrhea, and the onset should start at least 6 months prior to diagnosis and should be active within the last 3 months. To sum up the criteria, the patient should have recurrent bloating and it's the main symptom and should be active during the last 3 months, and this is should not meet the criteria for other functional disorders like IBS, functional constipation, or others. So most probably the diagnosis for the bloating and distension as a functional bloating should come from the patient words, from the patient complaint, not by any other investigation. And this is a very important problem because sometimes we can say that bloating and distension is a frustrating disorder. Why frustrating? Frustrating for the doctor because it's difficult to treat. Frustrating for the patient because the patient will ask you, please doctor, how did you diagnose me as I have a functional bloating or a functional disorder of the bowel? There is a specific test for this? No. There is a specific investigation. Please take blood test, take imaging, do endoscopy, do colonoscopy, and you did all, and all are normal. So what is the problem? And he is not responding well to treatment. That's why it's a frustrating disease for both doctor and for patients. As my friend and colleague Dr. Rauf said, we have some organic criteria should be excluded first, and then the functional disorders. And these functional disorders is related to the gut-brain interaction. Because the brain is not well, the gut will not be well. There is a connection, there's a wire between the brain and the gut. So if we have a good relaxing brain, if we have good mood, we will have good bowel. There is a great reflection between the brain and the bowel. This is to summarize the normal gas production and the excretion. We have two sites for gas production. The first one is the upper GI, the stomach. We have most of our gases from the swallowed air, the carbonated beverages that we eat. Then gas also is formed in the stomach because the HCl process involves carbon dioxide production. Some of them will be absorbed and some will go up again to be excreted with air and even with bleaching. Another point of gas fermentation in the colon, fermentation of the stools or the food remnants in the colon will lead to formation of gases. This fermentation is directly controlled by the colonic bacteria. That's why if there is any change of the colonic bacteria, this will affect the gases. So we can have gas from the upper GI or from the lower GI, from both of them. My colleague Dr. Raouf summarized the causes, the organic causes like SIBO, also disorder of the gut flora, abnormal motility of the colon and GIT, pelvic floor dysfunction, abnormal visceral osmotic reflex, and abnormal sensation, hypersensitivity of the GIT. Let's go through them. SIBO, with more carbohydrate fermentation, the overgrowth of bacteria in the bowel, the bacteria will ferment more carbohydrates, so will be more gas production and distension at the level of the small bowel. This carbohydrate intolerance will increase the osmotic load and the fluid retention and the fermentation with more gas production. So we will find more fluids and more gases, and this can cause bloating for this patient. Lactase deficiency by itself may not cause the malabsorption, but it can increase the visceral hypersensitivity and the tolerability to the gas produced by the lactase deficiency. That's why we can see some of our patients with lactase deficiency without bloating, and others may have lactase deficiency and bloating. Altered microbiota, no studies to show this. However, quantitative and qualitative differences in the intestinal microbiota identified in many patients with IBS bloating versus the healthy control. But it needs more studies to illustrate the role of microbiota in this disease. Altered motility at different levels. The first one, the gastroparesis. As we said in the pathophysiology, the problem could be from the gas production in the stomach. So if the patient has gastroparesis or delayed gastric emptying, which is accompanying many diseases like diabetes mellitus, for example, like those who are using some new medications, GLP-1 agonist or comparative medications, they may have some sort of gastroparesis. That's why they cannot get rid of the gas from their stomach, and they will complain of bloating and flatulence. Or small bowel dysmotility at the level of the small bowel, or colonic dysmotility with functional constipation. They cannot get rid of the stools, will lead to more fermentation, more gas production. The problem is the impaired gas clearance from stomach, small intestine, or colon. Gas will be retained, will lead to bloating. The same with pelvic floor dysfunction. They cannot get rid of the flatus and stools, so they will trap gases and lead to bloating. And this will be evident by prolonged balloon expulsion when we do high resolution anorectal manometry for these patients. The abdominophrenic dyssynergia is very important. This is the normal physiology. If we see here, if the patient has some more gases in the stomach or the colon or the small intestine, the abdomen, this gas will be tolerated normally by the patient. The diaphragm will go up to accommodate more gas. The abdominal muscle will contract, the abdominal wall muscle will contract to push the gas inside to keep it in the same place. And this is the normal physiology. In some patients, there is dyssynergia. Gas will have the upper hand. It will push forward the abdominal wall. It will relax. The diaphragm could not be relaxed and accommodate the gas. And this leads to bloating in this patient. Sometimes we can call this functional dyspepsia. And it's also part of the functional GI disorders. Finally, the visceral hypersensitivity. And as I'm trying to explain to some of my patients, if there is response to food, to drink, will be a regular response, a normal response. If someone put his hand over my shoulder, just trying to get my attention, what I will do normally, I will turn my head to him. So I will react in a normal action to his stimulus. But if I'm too much stressed, if I'm concerned with much issues, if there is a fighting inside my brain, if he just put the tips of his finger over my shoulder, at that time I may give him a knock. I may hit him strongly. Why? Because I'm so much stressed. This is the same situation in the bowel. The nerves, if I'm so much stressed, will be hypersensitive. So the normal distension, the normal gas inside my tummy, inside my colon, inside my small intestine, will be exaggerated. And the feeling will be as if there is an explosion inside my body, inside my abdomen. So this is an abnormal, exaggerated response to a normal stimulus. That's why the patient may come to me to say, Doctor, I'm eating the normal food. I'm eating healthy food. I'm following healthy regimen. I'm avoiding all diet fatty meals, spicy meals. And even though I have bloating, yes, because you are not sleeping well. You are sleeping 3 to 4 hours, interrupted sleep at night. You have too much stress. You have some problem. Please search inside yourself. And this is the visceral hypersensitivity. It's shared in the esophageal functional heartburn and the irritable esophagus syndrome, in the gastric problems and irritable gastric syndrome, or what we call functional dyspepsia, and also in the functional bloating, functional constipation, functional irritable bowel syndrome. How to diagnose? As my colleague said, we have to take detailed history. We should use breath tests for lactose, fructose, and SIBO to diagnose any of them. If the patient suspected for celiac, we have to follow up, to do endoscopy if needed, to do abdominal imaging, even to do gastric emptying study by scintigraphy to diagnose gastroparesis and to rule out that the stomach is trapping air in the upper part, cannot take rid of this. And after this, we have to treat this patient. How to treat this patient? First, I have to concentrate on the diets. Many of them, as I said, have normal, regular diet, avoiding all this slide, cannot eat all of this, and they are taking strict healthy food. However, they have bloating. This is abnormal response to the normal stimulus, exaggerated response, or as we saying, hypersensitivity, because he is stressed, he is not sleeping well, and so on. So not always the diet control will have an impact. We have to take it. We have to put it in consideration. But please, please, please rely on the patient. If he said to you, if he told you, I'm following a strict healthy food diet, but I have the problem. As my colleague said, we have to avoid artificial sweeteners and gluten, even if the patient he's not a celiac disease patient, he may have gluten hypersensitivity or intolerance. And this is in 70% of patients with bloating. And one of my friends told me, my father and my grandfather, they were eating gluten, normal food, and they have no bloating. Why in these days we have bloating to minority of gluten intake? Maybe there is problem in the great production for wheat and flour to cover the whole population, and this changed the genetic part of the gluten. That's why the gluten now is affecting many people, and most of them will have gluten intolerance or intolerance. And some of the IBS patients, some of the bloating patients are reporting not tolerability to gluten. Even the normal individuals, when he told you, when I stop pizza, food, bread, and flour and wheat, I feel much better. Yes, because 70% of population will have gluten intolerance. That's why we have to do it. There is some evidence that the food map, the restricted food map, the restricted fermentable oligo and monosaccharides may help with some patients, but the evidence is not clear and needs more studies to see this. If we said that there is a problem, as we said, in the microbiota, so the probiotics may have strong evidence, significant improvement in some patients with bloating, and the severity score will improve in these patients if they used probiotics. So this is another option we can try with this patient. What about antibiotics? Antibiotics per se may disturb the bacterial flora and can cause more fermentation because it disturbs the balance between the good bacteria and the bad bacteria, the good cup and the bad cup. It kills the good bacteria. So the overgrowth of the bad bacteria will lead to more gas fermentation and will lead to more bloating. That's why to restore this balance, we have two options. The first option, to give the probiotics. The second option, to give the rifaximin. There's some evidence that using the locally acting rifaximin to restore the gut microbiome and decrease the bacterial gas production. That's why we can use it in some patients to have this effect. Antispasmodics is very important, and in my opinion, I have to give the patient antispasmodic with all other modalities. So the cordial will be antispasmodic, and I have to add something for the to gas adsorb, something to restore the microbiota, locally acting antibiotics, and others. There are two large meta-analyses of antispasmodics focused on the symptoms of bloating and distension. The first one showed that the smooth muscle relaxation more likely to improve the abdominal distension in IBS patients compared with placebo. The other large meta-analysis showed that the antispasmodics were better than placebo, although the odds ratio will borderline, meaning that there is no significant difference between them. However, it's very important and should be considered the backbone for management of the bloating. If we go to the theory of the visceral hypersensitivity, so we can use the neuromodulators. Neuromodulators should be used cautiously with the patient. First, I have to tell the patient, take care, this is not antidepressant. I am not treating you from this depression. I'm trying to decrease the sensitivity of the nerves around your bowel, around your colon. So they will not be exaggerated response to the normal stimuli. First, I have to explain to the patient, because many patients will go home, will read the pamphlet, and will tell you, doctor, you gave me an antidepressant. I don't like to go with antidepressants. No, this is not antidepressant. This is very small dose to act as neuromodulators to decrease the pain tolerance in these patients. Amitriptyline or escitalopram significantly improved the postprandial bloating compared with the placebo. And in another study in patients with IBS, they took citalopram 20 milligram, then 40 milligram, up to 4 times per day, significantly improved the bloating. This is independent of anxiety and depression. This is not the dose, not the treatment of anxiety or depression. I'm giving neuromodulator for visceral hypersensitivity. And I have to explain this clearly to the patient. I should start with the lowest possible dose to increase the dose gradually and to monitor any side effects from these drugs. Simethicone is the anti-flatulent defoaming agent to relieve the symptoms of gas, because it will absorb the gas, absorb all gases from the bowel and take it to go out with this. Simethicone will reduce the surface tension of the air bubbles present in the GIT, and then these gas bubbles will coalesce together because there is no surface tension between them to make a gas bubble that can be taken out from the body. Exactly. And this action is maintained locally inside the bowel and is not absorbed, not metabolized. That's why it's very safe. The high dose of simethicone, 280 milligrams, has rapid effect on the patient. It's tolerable and safe because it's not absorbable even in pregnancy or in any other diseases you can give. It prevents gas bubble foam to be formed because it reduces the surface tension and the bubbles will coalesce together and easily released, and this will prevent and treat fullness and bloating. It's indicated for patients to relieve the bloating if they have aerophagia, air swallowing, functional dyspepsia, irritable bowel syndrome, peptic ulcer, any gaseous distension due to anything, even in post-operative gaseous distension. In pregnancy, it's considered category C. No study, as we said, but as if this is not expected to enter the breast milk and even not absorbed, not metabolized inside the body, it's safe in pregnancy. After all this, we can go to the biofeedback. Biofeedback, unfortunately, is not available in many countries, but in Europe and in USA, in some centers, they are doing the biofeedback for the functional GI disorders and bloating and abdominal distension. In a study of 45 patients with functional GI disorders with episodes of abdominal distension and bloating with an abnormal visceroosmotic reflex, they did biofeedback for them. 26 patients, they are utilizing the visual guidance provided by electromyography signals to allow these patients to control the activity and improve the distension. In short, the biofeedback sessions, I will use some influence on the patient using some visual activities, trying to make the patient try to control his symptom by himself. I will try to impress his brain. I will try to stimulate his brain by some visual stimuli to make him controlling his bloating and his abdominal distension and symptoms. It's successful in many patients and could be the final approach after all of the following, after all we said. Let's come to the conclusion. Bloating and gaseous distension are highly prevalent symptoms negatively affecting the patient, medical and economic and even activity lifestyle. Unfortunately, the symptoms are non-specific. So I have to take care and to ask well about this. The practitioner is thus faced with a number of challenges when evaluating the patient with symptoms of bloating and gastric distension. First, I have to identify if there is an organic etiology, and this will help. Second, to recognize the warning signs, as my colleague discussed in his presentation. Third, to assess dietary, medications, medical, surgical, behavior. I have to ask the patient, do you sleep well? 8 hours at night in uninterrupted deep sleep. Fourth, to consider many underlying physiological processes. As we said, we have many processes. And last, we have to provide a thorough discussion with the patient, give him some medications, and don't forget, finally, Sanficoon is the strongest to reduce bloating. We can give to the patient suffering from bloating and flatulence, and it prevent or reduce the discomfort linked to gas formation, and it's not absorbed and not metabolized. And this is one of our take-home messages. Thank you very much for your response, and I'm ready for any question.
Thank you so much, Dr. Mohammed, for this wonderful presentation that you have highlighted, translating all the evidence and the guidelines and the recommendations that touch the practical part using the simethicone to reduce flatulence. So with this second presentation, I would like to invite Dr. Raouf and Dr. Mohammed to be ready for the Q&A session. In fact, we have more than 700 and plus attendees in the past 1.5 hours. And I have one of the questions which has been asked by Dr. Ahmed Ibrahim. So Dr. Ahmed Ibrahim says, in real practice, which is the commonest underlying etiology for bloating and distension? Dr. Raouf, if you can kindly highlight this. In your practice, what is the commonest cause?
I would say the commonest cause is the combination between diet and psychology, and I mean the mood of the patient. And we are now very exposed to unhealthy diet, and we are exposed to huge stress. And this is can cause the main is the main cause and the commonest cause of bloating and distension. And I think Dr. Mohammed Zahri can have other insights.
Yes, please, Dr. Mohammed. Being sitting in the secondary level of practice, as a gastroenterologist, so what is the commonest?
Totally agree with you, Dr. Raif. Dr. Raouf. It's a combination between the dietary and stress. But in my opinion, the stress and the psychosomatic factor is the most important in this issue. And unfortunately, the patient could not treat this problem. Usually he will say, yes, but what shall I do? I have problem in work. I have a stressful work. I have a problem at home. I have problem with my colleagues. And for this, he will have persistent disease despite he has the cause for this disease. The stress is the cause, but he could not treat the stress, or he don't want to treat the stress. Of course, I'm telling them, you cannot change your work, you cannot change your home, but try to keep any problem away from mind. That's meaning try to suppress the stimuli from outside.
Mohammed, your voice.
You can deal with your work problem, making this to interfere with life.
Okay, all right. Thank you, Dr. Mohammed. Let me just highlight an issue here. We know that irritable bowel syndrome, 90% of those patients, they have bloating, and we have seen the efficacy and efficacious use of simethicone in reducing the bubble formations in patients with bloating. Yet, there is no guidelines available to use simethicone in irritable bowel syndrome. So what could be the reason for this kind of mispositioning of simethicone in the guidelines? Although the efficacy and the bloating, which is very highly prevalent in irritable bowel syndrome.
Because irritable bowel syndrome is a multifactorial problem. IBS, we don't have a specific etiology. So we have different etiological mechanisms. That's why we have to give a combination of treatment for all of them. If we have a look on the guidelines for the management of the IBS irritable bowel syndrome, we will have different lines. The first line is the antispasmodics, and they put about 10 to 12 examples for antispasmodics. Nothing of them have strong evidence and can be put at the first priority. No, they are saying choose one of them. If the patient is not responded, please change to another one. You can combine something for diarrhea. You can combine something for constipation, and you can add something for bloating. That's why we don't have a specific etiology, and we cannot put a specific drug for the management in the guidelines. But we have different etiologies, different presentations of the patient. That's why if the patient is coming with IBS plus diarrhea plus bloating, I can give him salmeticone, I can give him antispasmodic, I can give him loperamide, for example, for diarrhea. So it's a combination, but nothing to be put in the guidelines as a single treatment for one disease.
Okay, thank you, Dr. Mohammed. I think you have a problem with the voice. However, we will have a question to Dr. Raouf. Dr. Raouf, you know that there is the artificial sweeteners and caffeinated beverage and carbonated drinks usually lead to the bloating. So do you think the lifestyle modifications in terms of exercise and eating habits could be one of the cornerstone to overact this blanching and bloating? You are muted, Dr. Raouf. You're muted.
Sorry.
Yeah.
Of course, the sweeteners and the caffeinated beverage that we are consuming in huge amounts here in Saudi Arabia, mainly, I think it's one of the main diet mistakes that the patient are doing, and this is the main cause of irritable bowel syndrome and bloating and belching. And if we have the opportunity, and I have noticed that in many patients, when they are convinced to reduce the amount of coffee, we are not asking the patient to stop consuming the caffeinated, because it's our habit and we cannot get rid of this. We need to reduce the amounts of coffee and reduce the quantity of sweeteners, and the results is impressive. And we see that the patient are coming to say that we are really improving by the change of diet, especially by reducing caffeinated and artificial sweeteners.
Okay. Dr. Mohammed, regarding the combinations of simethicone with probiotics, antispasmodic, and tricyclic antidepressant, so how do you think that we can identify the sequence of using these medications one after another to manage those people with bloating?
First, I can use simethicone from the start, because it's safe and non-metabolized drug inside the body. So I can put simethicone with every step. The first one I will start with the antispasmodic. Then I can add, if the patient has some sort of diarrhea, I may add the probiotics to the antispasmodics. Finally, if the patient didn't respond to the 3 medications, I will add the neuromodulators. So I will start with simethicone with antihistamine bloating. Then second step, if the patient has diarrhea, I will add either rifaximin or probiotics. Then finally, I will add the neuromodulators after discussing with the patient and telling him this is not antidepressant, this is neuromodulator, just to improve the brain transfer.
Okay, thank you so much, Dr. Mohammed. Dr. Rauf, as an internist, you're working at primary care level along with the family physician. How long is the initial treatment considered to be failure? So, and when to refer the patients? You have mentioned it in your presentation, but how long we'll just keep on managing the patient with simethicone and probiotics, tricycline antidepressant, and when we should take the decisions after that particular period of time to refer the patient to gastroenterologist? You're muted, Dr. Rauf.
Yes, it's a very relevant question. It's the main question that we are in primary care as internists and as family medicine are asking ourselves, and I think there is no duration of the symptoms to refer the patient. It depends, because sometimes the patient is coming to you every week for the same symptom without an improvement, despite the escalation of the treatment, despite you have given him all the current therapies and options, but there is no improvement. I think at that time there is no time to try treatment, but always if there is no response to the treatment, if you have tried all the possible on all the potential treatment and there is no improvement, and if there is, as I said before, alarming symptoms, it's compulsory to refer the patient to gastroenterologist, because is not gas related symptoms, there is other underlying causes that need to be investigated and need to be treated in a more specialized level. And I think this point we should highlight it, because I see many of my colleagues that maintain the patient every time they come, they refill the treatment, even they didn't change the treatment. They refill the same treatment. The patient his symptoms can improve for a short time, and this is relapsing again. And I think this is not fair for the patient, and even not fair for the physician. It's important to explain to the patient that sometimes we need to go to the higher level. Maybe we need other investigation. Maybe we need endoscopy or colonoscopy. And this is very important. And I remember very well that, unfortunately, one of my patients, I have seen her after being seen by a gastroenterologist. She was seen by another internist for at least 2 years with alarming symptoms. And she said, I think I can believe her. She said that she's asking the doctor to refer her to the gastroenterologist because she's not improving. But he explained to her is this IBS, there's nothing to do. The gastroenterologist will not change. But when she goes by herself to the gastroenterologist, unfortunately, it was ulcerative colitis. And this is not this is the mistake that should not be done by everyone. I recommend primary healthcare professional, family medicine, internist, if your patient is not improving, maybe after 1 month, maybe after 2 months, but if he's not improving and there is alarming symptoms that you need to look for, maybe the patient, I know that my patient, most of the patients are going in the clinic and saying, doctor, I have IBS, please give me refill the treatment. The patient giving you the diagnosis, and this is very misleading. And it's important to seek for the alarming symptoms and to see how the patient disease is outcomes, and it's never late to send the patient, to refer the patient to gastroenterologist.
Okay, thank you so much, Dr. Rauf. In your presentation, you have emphasis on 2 important points. One is proper taking the history to differentiate between the gastric bloating or a small bowel bloating, which is less than 30 minutes or more than 30 minutes. So how this can be applied on the real world practice, taking the proper history. This is one point. The other point, you have also emphasis on the biopsychosocial approach to patients with functional GI disorders. So it's not only the symptomatology from somatic point of view, but also the social impact as well as the psychological impact in terms of depression. So if you just can highlight on this, please.
I think we usually, unfortunately, especially in private practice, we don't have enough time to do physical examination to ask the patient the question. But the patient is not coming for only one time. You have to. You will see. I see my patient mainly maybe for 1 month. I see 2 or 3 times, and at that time I have the full story, the full history, and I have the time to examine and to collect all the data about the patient. And at that time, I will have enough idea about what the patient have. It's really a functional symptom, and there is nothing to do, and we should live with, and we should improve it, or it's time to refer to the specialist, to gastroenterologist. The psychosocial issue is very important because I'm working in Jbeil, and most of the population is active population, and the main complaint, and sometimes the patient is not complaining about the symptoms, he's complaining about his relation. I remember several times to hear about from the patient, doctor, please help me, I cannot attend the meetings, I'm leading a meeting, but I cannot finish the meeting because of diarrhea, because of bloating, because of the sound of gases, and this is very embarrassing. And because it's aggravated because of diet, and also because of stress of the meeting, and this is very important. Unfortunately, the patient cannot handle very well the situation of the stress, and cannot work with stress, and this is, I think, the main part of gas-related disorders that cannot be solved. And we can, I think one of the idea is for the physician is to empower the patient and to explain to him that the solution comes from him. And I think especially for this bloating and belching, is the solutions coming from the patient, because we are given solutions and we are explaining the disease, and the patient, if he follows the good diet, healthy diet, and if trying to get rid from stress and reduce the impact of the stimuli of stress on him, he will improve 100%, and we are seeing this in many patients.
Thank you. Thank you, Dr. Rauf. Dr. Mohammed, now you know that we are living in an era that new molecules has been introduced in the management of diabetes and obesity, like the GLP-1, which you have mentioned it clearly. So we have the semaglutide, we have tirzepatide, which has been used extensively in diabetic patients, apart from the obesity. And we know that diabetic patients, one of the complications is gastroparesis, and the GLP-1 decreased the gastric emptying time. So with this kind of complicity in bloating and abdominal distension, what is the role of simethicone, and what is the perfect combinations to reduce this kind of annoying symptoms?
Thank you for this nice question, Ashraf. Really, it's a problem, and this is a dilemma how to manage this patient, because we want to take care of this patient for diabetes. We want to cure him, we want to control the blood sugar, and on the other hand, the patient will come complaining of bloating, severe bloating, and that's what we are in. So first I have to explain to the patient, because we are aiming to control either your body weight alone or your body weight and blood glucose level. So we can have some side effects. We have to accept them, because this is what we have to pay to get the treatment. That's why we have to tell the patient. This is the first thing. Second thing, I have mild bloating accepted by the patient, moderate bloating accepted by the patient, severe bloating. Severe bloating, I have to test for gastroparesis immediately, because I saw 3 to 4 cases in the last 6 months, especially with the GLP-1 agonist. They have severe gastroparesis even after they stop the medicine, the GLP-1 by 1 month. So for this, bloating will be alarming for us. I have to stop the medicine immediately. I have to test for gastroparesis. I have to give prokinetic for this patient. If he has mild to moderate bloating, nothing to be done for the time being, just to give him simethicone. I cannot give him prokinetic, because already the patient, I'm giving him a drug that is not, it's against the prokinetic. It will not give, it will slow the gastric emptying, will delay the colonic emptying, will delay the intestinal emptying, and this is the mechanism of action. So I'm not supposed to give him prokinetic, and also I should not give antispasmodic because antispasmodic will lead to more problem in this patient. Will relax the bowel mode, and he has already delayed bowel movement. So simethicone will be optimal for him in the mild to moderate cases. In the moderate and severe cases, we should take care of this patient may come in with gastroparesis. But I have to do scintigraphy and immediately stop the drug and try to solve it by another medications or maybe interventions.
Okay. Thank you, Dr. Mohammed. Dr. Rauf, there was a questions, the combinations of simethicone with the charcoal tablets, which is very frequently used, and the mebeverine, for example, in patients with irritable bowel syndrome. So this kind of combination, how this is applicable in your practice in managing patients with irritable bowel syndrome with flatulence?
Yes, it's usually very common. It's very commonly used, and in some patients there is a good response by the association better than the use of a single medication, or for example, mebeverine or simethicone, associated or no with the charcoal. And I think it's very personalized. Sometimes the patient is asking that he's saying to you that I have good response with the association, and sometimes he explained to you that please don't give me this one, I have tried it and it's not efficient. And the response is very diverse and very different from a patient to another. And I think it depends on the every patient, and it depends on the experience of every physician.
Okay. Just one last question for both of you. اتفضل دكتور. Yes, please.
Yes. Charcoal, activated charcoal usually cause some sort of diarrhea. So it should not be used in those with IBS, bloating, and diarrhea. Of course, IBS associated with constipation is associated more with bloating. However, if this patient has some sort of diarrhea, I should not use either the combination or the activated charcoal. I should use simethicone only. It's better for him.
Okay, perfect.
Because charcoal will cause more diarrhea for this patient.
Excellent. طيب, Dr. Rauf, Dr. Mohammed, one last question I would like to forward it for you, because we have family physicians, we have primary care physicians, and we have pharmacists, community pharmacists as well. So what is your final advice to those professionals in the management of bloating and abdominal distensions with simethicone? Dr. Rauf.
I would like to say that it's very common symptoms, and we should not banalize the symptom and reassure the patient without being sure about what is behind this. And I think we need to do good detailed examination, detailed history taken, and detailed and good physical examination, and looking especially for the alarming symptoms, and giving the patient the appropriate treatment, and then see the patient on the follow-up to see what is the outcomes of his disease. And later on, we will need to refer him if there is no improvement or there is any complication, to refer him to gastroenterologist.
Okay, thank you, Dr. Rauf. Dr. Mohammed.
Let me divide them for the family care physicians and specialists. First, as Dr. Rauf said, we have to exclude the alarming red flag signs. If this is not present in the patient, you can treat him, and if he didn't respond, you can refer him for the gastroenterologist. For the pharmacist, please give him something not metabolized, like simethicone, and refer him to the family medicine physician, and he will continue the track with it.
Okay. Thank you so much, Dr. Rauf, Dr. Mohammed, for this wonderful presentation. And I think coming to the end of these scientific sessions, because we are almost there. So I would like just to say final words, just to highlight the importance features of the presentation to our colleagues in primary care physician and the pharmacist, that abdominal bloating and distensions are highly prevalent symptoms, usually we encounter in our day-to-day practice. And usually we witness the negative impact of these symptoms on the patient life and the psychological impact as well. So we get depressions, anxiety because of these symptoms, especially when it impair the quality of life of patients. Unfortunately, the symptoms of bloating and distensions, non-specific. And for us as a family physicians, when we deal with a patient with bloating and distensions, we have to consider 5 important steps to go with. The first one is to identify the underlying etiology. This is very important. And then we have to search for the warning signs and the red flags to make sure that we are just dealing with a functional disorder rather than a structural one. And then we have to assess the dietary and the medications, the surgical, the behavior factors that contribute for the bloatings as a problem. And then we have to underline the psychological process and the impact of the problem on the patient. And we have to provide thoughtful discussions with the patient in order to understand, highlight all the features of the problems. And finally, we have to consider simethicone 280 milligrams as a strong molecules to reduce the bloating, especially for those patients with functional gastrointestinal disorder. So with this, ladies and gentlemen, I would like on your behalf to thank Dr. Raouf Haji and Dr. Mohammed Zahri for the wonderful contribution for the great success of this scientific event and enriching all of us with this kind of thoughts, ideas, and updated informations, which is evidence-based. And I hope that what we have learned today, we will carry along with us in our clinical practice to make our patients with flatulence and abdominal bloating relieving the symptoms with these kind of medications. I would like to extend my thanks to Stada company for giving us this wonderful opportunity to be together today in this wonderful month of Ramadan. Special thanks goes to Fexus, Multaqa Al-Khibrat, for this wonderful organization. So thank you very much for all of you, ladies and gentlemen, and I hope that we are going to see you back again, inshallah, in other presentations. And stay tuned with us. Next week on Friday, we are going to have another session. We will be physically in Riyadh and virtually transmitted throughout the channels to every single healthcare providers across the kingdom, inshallah. Thank you very much and have a wonderful day. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.